Hi. Okay. So when I was asked to give this presentation to share the voice of patients and their advocates, Dr. Fleming asked me to think about close concerns 10 years into the future. As background, Close Concerns is an organization founded by Kelly Close focused on insights in diabetes, prediabetes, and obesity. We're based in San Francisco, and we research and write a newsletter called Closer Look, where we essentially watch announcements on the latest in diabetes drugs and technology, and we write about that for our readers. But I started envisioning this future where we have great therapies and we have great devices for diabetes, so let's pretend there's really not that much more to do there. Whether that'll take 10 years or 9 or 11 or maybe a little bit longer. But in 2027, I think that while Close Concerns associates will still be thinking about managing diabetes and obesity, hopefully they'll be thinking far more actively about how to prevent these conditions. And hopefully the healthcare system has shifted so that instead of just reacting to diagnoses, we're working more proactively to keep people healthy. For context, these are some of the headlines that I've written recently at Close Concerns. So this one is about Novo Nordisk's GLP-1 agonist Victoza and a new cardiovascular indication. And importantly, it applies to type 2 diabetes patients with established cardiovascular disease. And this is a similar piece that we wrote about Johnson & Johnson's drug Invokana, requesting a label update. Again, that would apply to adults with type 2 diabetes who have established cardiovascular disease or very high cardiovascular risk. Now, to be clear, this is really significant progress, and I don't want to undersell that. These headlines reflect a movement toward outcomes-based medicine, where patients are really receiving prescriptions not just to lower their average blood sugar, but actually to prevent heart attacks and hospitalizations. And that's really exciting. And in this way, Close Concerns is already focused on prevention, but maybe more secondary prevention. Because it's true that in my day-to-day writing, I'm pretty much thinking about clinical trials in very sick populations. These cardiovascular outcomes trials in particular enroll patients with a longer duration of diabetes and often comorbidities like dyslipidemia and hypertension. So Dr. Fleming's questions really got me thinking about what headlines might be like 10 years from now. Hypothetically, maybe something like this. The Toronto Waterfront Project, now with 10 years backing from Google, helps every citizen get the recommended 60 minutes physical activity per day, cuts prevalence of obesity in half. So the background on this is that there's been an enormous revitalization effort in Toronto where the city is taking advantage of underutilized space to create parks and other areas to walk around. And a couple weeks ago, Google's parent company, Alphabet, announced that it'll build a new district along the waterfront. So with the introduction of more funding and technology, this project could really take off. Another hypothetical headline: last handful of schools ban sugar-sweetened beverages. Public health leaders credit UCSF for paving the way. The background here is that right now, the University of California in San Francisco is the only medical school that's completely gotten rid of soda on campus. But we know that soda is the most common source of added sugar in the American diet. And after Mexico implemented a 10% tax on sugary drinks in 2014, they found a 12% drop in soda purchases for the average household. So projection research suggests that over 10 years, so Mexico in 2024, the soda tax could save $983 million. It could prevent 20,400 strokes, 18,900 deaths, and 189,300 cases of diabetes. So maybe our headline would be something like this: type 2 diabetes prevalence falls markedly for 10th consecutive year. That's probably a stretch because in order to write that article, we'd have to get prevalence down very appreciably starting this moment, and we're trending in the wrong direction right now. So if you take a look at these maps of the United States, starting at 1985, and these show obesity rates state by state according to the CDC. And you'll see that they get more colorful as I click through, which in this case is a bad thing. And we're going to go up to 2016, where no state is below 20%, and 5 states actually have 35% or more of the adult population with obesity. Importantly, though, these findings were based on self-report data, and NHANES does a bit more of a rigorous study every 2 years where they're also looking at physical exam records. So our team put together a map of what we think 2016 actually looked like if you use that more rigorous assessment, and it's even darker than that. So NHANES released its 2015-2016 survey just a few weeks ago, reporting near 40% adult obesity prevalence and near 19% childhood obesity prevalence. We saw this image a few times yesterday already, so clearly it's making an impact on people. But if you go all the way back to the beginning of the century, prevalence was just under 31% in adults and 14% among youth. So undoubtedly we're heading in the wrong direction towards a future like this instead of a future like this. And that's not to say there's no hope, because the Toronto Waterfront Project, I think, is really exciting and it's really taking off, and UCSF really did successfully ban soda. But on the flip side, you also have places like Chicago repealing the soda tax that passed last election, which just goes to show that we can't lose sight of the prize, and we have to keep working really hard toward these goals. I was at the Cities Changing Diabetes Summit in Houston last week, and I think they've done a really excellent job balancing a message of hope with a message of urgency, which is really key. So the program just set a bold goal, calling on every city to cut obesity by 25% so that global type 2 diabetes prevalence doesn't rise above 10% by 2045. So keep in mind that 10% is still 1 in every 10 people with a preventable disease. Global prevalence right now is about 1 in 11, so the program does acknowledge that this will probably get worse in the next 3 decades. But by taking action, cities can start bending the curve, so to speak, so that that upward trajectory can maybe start to point down. At the summit, we heard some early success stories from the cities currently participating in the program. So that includes Vancouver, Copenhagen, Houston. And local health leaders were really focused on this exchange of ideas so that other cities can sort of learn what's working and see that this is totally possible with hard work, rather than just being resigned to bad public health outcomes as if they were inevitable. And as an advocate for patients, and as someone who has a history of type 2 diabetes in her family, there are a few important things I'd like to see accomplished in the next 10 years. And these are some items that I think could be really powerful to engage people in their own health, which is the only way to make prevention a real success story. Number one, I think it's super important that we reduce stigma, and if we can, eradicate it altogether. So how can these maps look so different? If the CDC reports that the highest statewide prevalence of obesity is 38% in West Virginia, but then NHANES reports that the national prevalence is actually 40%. I've never been great at mental math, but clearly if 40% is the average, then that means the real obesity rate in many states is actually much higher than that. But there's so much stigma in talking about obesity that people greatly underestimate it in self-report data. Now, I think it's tempting to sit back and say that celebrities should do a lot of the hard work here. Tom Hanks has type 2 diabetes, and I wonder why he doesn't go on talk shows and start talking about his time in range, and maybe he could make it okay to have this disease so that we can all start talking about it more openly. That's what I'm tempted to think as well, but as our good friend at Close Concerns, David Lee Strasberg says, Hollywood is not going to save us. Don't hold your breath. It's not going to happen. Because Hollywood does not lead, it reflects. It picks up on conversations that people are having, and then it amplifies those human experiences. So if not Hollywood, then what's the solution to pervasive stigma? I have some ideas on what I think patients need to feel less stigmatized. Foremost, because I was a student not too long ago, I think about college campuses where there's a big sense of social responsibility around donating blood and showing up for the annual bone marrow registration drive and getting a flu shot. There's even a pretty big sense of social responsibility around getting tested for STDs now, just because people feel like they need to be knowledgeable about their own health. And that's not a disease area that's easy to talk about. So if we can overcome that stigma, perhaps we can get students more engaged in A1C testing. Not because that's the most important number in prediabetes or diabetes, but just because as you get people engaged in their own glycemic control, it can help normalize these conversations. And once students feel more compelled to understand risk factors for diabetes, that prompts conversations with parents and grandparents, and that could be really promising. Language is also really influential, and it can perpetuate stigma or it can kind of work to combat it. I think in diabetes, people have largely swapped out the term diabetic for the phrase person with diabetes for the most part, and it would be really great to see a similar transition happening in obesity, where instead of always referring to people as obese, we're really thinking about them as people with obesity who are just afflicted by this biological disease. A terrific paper on language was just published collaboratively by the ADA and AADE, where they came up with a list of recommendations around language use in diabetes care and diabetes education. And the paper emphasizes that this is definitely important for patient-provider interactions, but also sort of recommendations for the general public media to use, because that really shapes public perceptions of diabetes. So realistically, it's going to take a lot more than one publication to shift those language paradigms. But while we're imagining the future, how fantastic would it be to have recommendations like this pertaining to all chronic disease? This image also pops to mind. These are NFL football players wearing pink to support breast cancer awareness, which was particularly effective because it put at center stage these individuals who aren't personally afflicted by the disease, but who are acting as advocates for it. And replicating this for diabetes and obesity, I think, could be really powerful. There are plenty of professional athletes who have family members living with these conditions. There's definitely professional athletes at risk for these conditions. And interestingly, they have really different visible body shapes and body compositions, and these are people who exercise at high intensity. So might we be able to find some anti-stigma advocates in this group? And lastly on stigma, this is Sami Inkinen. He's the CEO of Virta, which is this online specialty medical clinic helping people reverse their type 2 diabetes. Believe it or not, Sami was diagnosed with prediabetes just a couple days after winning a triathlon. He may not be a celebrity in the classical sense, but he does help prove my point that it's possible to set the record straight. It's not about image, and there's nothing cosmetic about obesity care or diabetes prevention, and that's the message that we really should be sending. It's stories like Sami's that might eventually be amplified by Hollywood, but we have to lay the groundwork. Okay, what else do we need to promote health, engagement, and prevention? Well, I think we can't ignore economics, because people are motivated to save money, and unhealthy foods happen to be what's cheapest in most cases. We also should appreciate time, I think, as a resource, because when people are commuting hours each day to and from work, they might not necessarily have time to exercise, and in that time, when they're just sitting in their cars, they're completely sedentary. So in addition to affordability, I think we should talk about the future of built environments and how they can foster health by making the healthy choice the easy choice. A few weeks ago, I was at the FDA for an advisory committee meeting, and I couldn't find water in the cafeteria. So they had 8 different types of soda, but no water. And at the ADA scientific sessions in June, I remember that there were these Mrs. Fields cookie stands in almost every hallway. And the cookies are really cheap, and they go really well with the coffee that we were getting for free. And to get a healthy snack, I would have actually had to go pretty far out of my way. So this built environment was making the unhealthy choice so blatantly available to me and was asking me to put a lot of effort and extra burden into making healthy decisions. In contrast, at Novo Nordisk headquarters, US headquarters in New Jersey, they sell one slice of pizza for $10 and they sell salad for $2. So that's kind of an example of the good nudging and incentive that we might use. I think it's really fascinating how often people will just follow what's default. So behavioral economists have spent a good deal of time unraveling this. And just for example, say that at this meeting we were asked to fill out a form for lunch, and we could pick if we wanted a burger or if we wanted salad. So there are a few different ways that you could design that form. You could just ask people to select one or the other. You could sort of assume that everyone wants a burger and just say that, give them the option to opt out. Or you could make salad the default and give people the option to get a burger instead. And so we know that people are quite biased towards the default option in scenarios like this. So most of us would be eating a burger for lunch in scenario 2 and would be eating a salad for lunch in scenario 3. And it could just be with simple moves like this that we start to encourage healthier eating. In addition to diet, we also want built environments that encourage physical activity. So at Close Concerns, we always talk about how we'd love to see buildings designed so that the stairs are front and center when you walk in. And this is already starting to happen at places like the Whitney Museum in New York City, which is really exciting. But even with something simple like that, it makes it slightly more effortful for people to take the elevator just because it's at the back of the building. And that way, when I arrive somewhere, and most people aren't really thinking about healthy decisions minute to minute, right? They're just living their life and getting where they need to go, then they're more inclined to just do what's right in front of them, which would be to take the stairs. Toronto and Copenhagen are examples of this on a slightly larger scale because those cities are designed with safe sidewalks and bike lanes and community parks to encourage physical activity and to make physical activity more of the social norm. In contrast to that, when we were in Houston last week for Cities Changing Diabetes, it was actually we could hardly even find sidewalks, and it felt pretty unsafe to walk around because of the traffic and because there were broken crosswalk signals. So that's kind of exactly the opposite of what we want. And we need to appreciate that built environments can facilitate health-promoting behavior when they're designed correctly. So one of my fondest wishes is that in 10 years, everyone has realized this, from healthcare professionals to patients and consumers to policymakers and city planners. And one last point is that I think there's a knowledge gap, especially when it comes to nutrition. And nutrition information is still very confusing for people because there's a lack of consensus. So people might read on one website that bacon is healthy because it's ketogenic, but on a lot of other websites that it's the last thing that you should ever eat. As author Gary Taubes has said, who wrote The Case Against Sugar, How is it that we're getting ready to colonize Mars, but we don't yet know what to pack for the journey? I think people who are asked to be healthy in this society of really cheap fast food, at the very least, deserve some clarity on nutrition. Third, I want to imagine what patient-provider interactions could look like in 2027. I'm not a patient with metabolic disease right now, but let me tell you that I feel pretty awkward at a lot of doctor's appointments. One, because they're inconvenient to schedule, but also because when I'm there, it's easy to feel like you're just taking up someone's time who's really, really busy and could maybe be spending that time with people who need it more. But of course, as we shift towards prevention-focused healthcare, that's exactly what we want. We want people to see a provider before the onset of disease. So as things stand, people ask more questions right now when buying a refrigerator than they ask to their doctor. And I think that highlights the difference between consumers and patients, because consumers feel a lot more ownership over the things they're buying, and they feel entitled to all the information they want before making a decision. And patients don't really feel that same ownership over their own health, which is really dispiriting because developing a disease like diabetes will have a much greater impact on your life than one refrigerator model versus another. I think we should also acknowledge that we need to do a better job supporting providers in this movement. So decision support systems could pave the way here, because patients don't want to sit around waiting while their doctor has to input information and read charts. But once we have established tools that help make those treatment decisions, patient-provider conversations can focus more on what really matters, like what priorities are most important to the patient, what questions does the patient have. And we hear really often at diabetes conferences that doctors are spending way too much time on prior authorizations. So the average we hear is about 15 minutes for each one, and that ranges all the way up to 90. And that's a lot of precious time stolen away from the patient that could be spent answering questions and developing more of a trusting relationship. So I'd love to strive to reduce that administrative burden so that every patient-provider interaction is a lot more fruitful. This fourth wish I have, I think, is already underway, and I want to acknowledge the efforts FDA is making to heed patient voices in the regulatory process. That said, I hope that's greatly amplified in the years ahead. So take Metformin as an example. We've already talked about it a lot at this meeting, so I'll keep my comments pretty brief, but it's generic, low cost, approved for type 2 diabetes, but not prediabetes, even though it's shown some prevention efficacy. And I think maybe patients can decide if that's a pill they'd be willing to take in order to prevent diabetes. As Dr. Bob Ratner said recently at that FDA advisory committee meeting, it was for semaglutide, but he made a really eloquent point, I think, which is that FDA can put all the risk-benefit information out there on detailed product labels, because that's what's going to empower patients to ask more questions, and it's what will empower physicians to provide answers, and that's a way to meaningfully move toward personalized medicine. But we can't do that unless we have the options out there. And I think this kind of speaks to the need to generate more public uproar over health issues. So if people can show up to town hall meetings to protest a new Starbucks moving in, then I think they can do the same to support anti-disease policies in their community. As one example, UCSF has piloted training programs to teach people how to speak about public health matters when there are venues like town hall meetings for their voice to be heard. And last year we had pretty decent showings of support for the soda tax in San Francisco. So all of this culminates, I think, in my fifth wish, which is that by 2027, we'll have more of a pervasive sense of health citizenship. Because ultimately, people do need to take responsibility for their health and well-being, and for the health and well-being of people around them. But that starts with strong built environments and anti-stigma efforts. Hordes of people have embraced their role in protecting the environment, now and for future generations. And it would really be something if all people began to feel this responsibility for health just as fiercely as they feel it to recycle and to reduce their carbon footprint. So I'll end on this question because I think it really captures what I imagine Close Concerns is writing about in the future, hopefully not too far into the future. What will it take to foster that health citizenship? Because I think that's really at the crux of prevention-focused healthcare. And finally, I just want to take a moment to thank Kelly and my colleagues at Close Concerns and the Diatribe Foundation, and to thank our conference organizers for putting together this really awesome meeting.